we'd like to start with a second lecture with Professor Thomas Karlas from Leipzig, and he will present on indications and limitations of shear wave elastography of the liver. Warm welcome, Thomas. You did a great job for our guidelines and you are a leader in that field. We very much appreciate your lecture and looking forward. Thank you so much.
Welcome to everybody. I'm glad that I was invited to give this presentation on indications and limitations of liver elastography. So these are my disclosures. And I just want to say that all recommendations of this talk are based on the current guideline update, which you can read and find here. So before pushing the button for elastography methods, we need to know what we want to know. And elastography is a method of diagnostics of chronic liver diseases. And as everybody knows, we have a continuum from a healthy liver over inflammation and accompanying steatosis, over progressing fibrosis to the final stage, cirrhosis and portal hypertension. And of course, morbidity and mortality increases with progressing disease. And we make use of the fact that liver stiffness also increases during the course of chronic liver diseases. The basic aim of liver elastography is fibrosis staging. And now the question, how can liver stiffness measurement help? Here's an example from a large study from Romania on point shear wave elastography in patients with chronic hepatitis C. And as you can see here, the shear wave velocity increases with the stage of fibrosis and up to liver cirrhosis. And there's a portion of patients where we can rule out significant fibrosis with high confidence, and there's another portion of patients where we have a very high probability of advanced fibrosis or cirrhosis. So in all these patients, we can avoid liver biopsy when using liver elastography. But however, there's a small proportion of patients which ends up in a gray area where we need liver biopsy if this influences our management. So this is the basic idea of fibrosis staging using liver elastography. It is a numeric measure and thus it is objective. We can share it with colleagues, we can repeat it. It is performed fast and it's reliable and it has a good inter-observer agreement, and it performs better than conventional diagnostics of liver cirrhosis, for example, the conventional signs on B-mode ultrasound. What we need to take into account is that the best evidence we have is for vibration-controlled transient elastography, the so-called FibroScan device, and we have fewer evidence for further elastography methods. When focusing on different etiologies, we start with viral hepatitis C because this is the disease where elastography has been evaluated best. In patients with viral hepatitis C, we can use liver elastography for detection or exclusion of fibrosis and cirrhosis at the initial presentation. And this is very useful to start preventive measures, for example, the screening for hepatocellular carcinoma. And it might also have meaning in limited resource settings where treatment is not available for everybody. Then we can stratify patients by the presence of fibrosis or cirrhosis. I would also like to mention that liver elastography combined with serum-based fibrosis markers can lead to a better diagnostic accuracy for detection of fibrosis and cirrhosis, and this is what is recommended in the current EASL guidelines for hepatitis C. So they suggest to combine two non-invasive methods, for example, the transient elastography with biomarkers, and if we have concordance in the findings, we can avoid liver biopsy, and only if there is doubt or any other question, and if the biopsy will influence the management, we need to perform liver biopsy. What about hepatitis B? In hepatitis B, liver elastography can also be used for detection of fibrosis in patients with chronic active infection, and it may also be used to rule out significant fibrosis in inactive carriers of the virus. However, viral hepatitis B is characterized by inflammatory activity, and that need to be considered when interpreting the results. Again, we can have a look on the current EASL guidelines, and as you can see here, you need to stratify patients by the presence of ALT elevation. So you will find different cutoffs for severe fibrosis or cirrhosis in patients with normal ALT compared to those with ALT elevation. And special attention should be paid to patients with high ALT values above 5 times the upper limit of normal. There, the measurement might be not accurate. Non-alcoholic fatty liver disease is another indication for liver elastography, and it's very interesting for the future because of its very high prevalence. However, we have the problem that liver elastography is less precise than in viral hepatitis, but it's still reliable enough to rule out cirrhosis in the majority of NAFLD patients. When performing liver elastography in NAFLD or NASH, we have several confounders like the steatosis and also the NASH activity. It's the same with viral hepatitis B. If there is inflammation, this may lead to higher values. Again, a combination with serum-based fibrosis markers may improve diagnostic accuracy, and there are screening algorithms using either fibrosis-based markers, serum-based markers, or liver elastography under evaluation for risk populations like patients with type 2 diabetes mellitus, and we will see results and recommendations in the near future. There are further implications for the use of liver elastography, such as alcoholic liver disease, where it can be used to rule out cirrhosis, but before performing it, we should rule out that there is acute alcoholic hepatitis. Further implications are autoimmune and cholestatic liver disease. However, there is limited evidence, and there are many confounding factors such as inflammation and cholestasis. However, there was a large study which showed that liver elastography may be a very useful method to determine prognosis in such patients, and we will learn in the future whether this will be implemented in clinical guidelines. Another point, which is the common final stage of liver disease, is portal hypertension. And there we know that a very high liver stiffness above a cutoff value of more than 20 kilopascals indicates that patients have a high risk of portal hypertension, and special attention should be paid to such patients, and they should undergo screening like gastroscopy. And the other way around, the liver elastography, especially FibroScan, may help ruling out large varices, especially in combination with a platelet count in affected patients. However, when interpreting liver elastography results, we need some knowledge about interfering factors. I guess Giovanna will tell us something about the underlying technical factors, but there are things of like device and protocol which need to be considered, and also the examiner needs to be qualified and needs to take many clinical points into account when interpreting the results. Especially, he needs to focus on concomitant diseases, the patient's anthropometry, the etiology of the liver disease, and the hemodynamic situation of the patient. As I told you before, liver elastography aims to stage fibrosis non-invasively, and you will find manufactured material like presented here, which surrogates that fibrosis can be staged very accurate as long as you take etiology into account. But I want to remind you that elastography methods are not precise enough to distinguish single stages of fibrosis, but they give you an impression of the risk of advanced fibrosis and presence of cirrhosis. So fibrosis and cirrhosis cause elevation of liver stiffness, but there are also other factors which may cause the same. So liver perfusion may modulate liver stiffness, and this is especially relevant in patients after meal ingestion, patients with central venous pressure increase, or malign diseases, vascular thrombosis, etc. And on the other hand, we have conditions which modulate the tissue pressure, like inflammation, necrosis, or biliary obstruction. And now I will show you some examples of that. This is a patient with bile duct dilatation, and there are nice works showing a direct relation of biliary obstruction and liver stiffness. So after drainage, liver stiffness decreases, and when the drainage does not work anymore, liver stiffness increases again. So in patients with increased liver stiffness, bile duct dilatation needs to be ruled out by sonography. And the same is true for congestive liver disease, for right heart insufficiency. Here you can see from an animal model that there is almost a linear relation between central venous pressure and liver stiffness. So special care should be taken in patients with right heart insufficiency when interpreting liver elastography results. And again, in acute hepatitis or necroinflammation of the liver, such as acute liver failure, results should be interpreted very carefully, because there's a direct relation of ALT and AST values with increased liver stiffness, even in the absence of fibrosis. So acute liver failure might mimic cirrhosis, although it is not present. And what is also important to know, that the alterations of liver stiffness may persist for weeks even after the clinical recovery of the patient. When applying liver stiffness measurement, we also need to know where are the limits of the method, and this is of course patients with advanced stages of obesity. So if you have a high skin to liver capsular distance as shown here, it will be hard to gain reliable results, even when applying special probes designed for obese patients. And the higher the measurement depth, the lower the precision, and there is still some uncertainty regarding the cutoff values in obese NAFLD patient cohorts. And also we need to take into account that there might be interference with steatosis, and so the recommendation is that careful interpretation of fibrosis station is necessary in obese patient cohorts. Some words on meal ingestion. This is a very important point. Meal ingestion increases the liver perfusion and may lead to significant increases in liver stiffness, as shown here in a work from Spain in 2013. There's a patient with F2 fibrosis, and shortly after meal ingestion, liver stiffness raises up to 15 kilopascal. So the same is true for point shear wave elastography, where we see dynamics over 2 hours. So the recommendation is that patients should fast a minimum of 2 hours before undergoing liver stiffness measurement. However, there is still some uncertainty when the liver stiffness definitely normalizes, and there is a recent work which followed up patients for 3 hours, and they still observe an increased liver stiffness after meal ingestion. So at our institution, we normally require a fasting period of 4 hours, and I recommend even overnight fasting in special situations like clinical studies. And yeah, one further point which is important nowadays, there are more and more technical devices dedicated to liver elastography, and there is some uncertainty regarding the units of measurement, so kilopascal versus meter per second, and device-specific cutoff values, and also there are quite different measurement protocols and indicators of reliability between transient elastography, point shear wave elastography, or 2D shear wave elastography methods. And on the other hand, we have the problem that we have an increasing number of devices that require evaluation, but a lower frequency of liver biopsy because the already evaluated methods work very good. So we have a problem in gaining new evidence for new approaches. Last pitfall, the measurement position. Normally, liver elastography should be performed through a right intercostal space in the right liver lobe, which is shown here for the transient elastography or here for a 2D shear wave elastography setting. But there will be situations, as in this patient, where you have a large cyst in the right liver lobe, where with point shear wave elastography or 2D shear wave elastography, one might aim to measure other segments in the left liver lobe or try a subcostal approach. And the subcostal view is associated with a lower precision of the measurement values, and we will find higher values in the left lobe. So this should be taken into account when choosing the measurement position. So recommendations for pitfalls are: you should take into account liver inflammation, you should rule out obstructive cholestasis and liver congestion, and you should be aware of acute hepatitis and also of malign or infiltrative liver diseases. This is my summary. Liver stiffness measurement improves the detection of fibrosis and cirrhosis, especially in patients without evident clinical symptoms. And liver elastography is an established method for staging disease severity in chronic liver diseases, especially for patients with viral hepatitis C and B. And for users, it's important to know their device and its specific limitations. They should take into account etiology and concomitant diseases. And liver elastography findings should always be interpreted together with the B-mode ultrasound and lab result findings. Thank you for your attention.
So, thank you very much for this very precise presentation about indications and limitations. So, from the audience worldwide, there's one question, eventually I might ask right now. Congratulations, does ascites change liver stiffness measurements? Would you or could you please comment on this?
Yeah. So ascites is a problem. Patients with ascites have been excluded from most trials, so the knowledge is limited, and it increases measurement depth, and thus the precision will be lower. But of course, patients with ascites will have advanced liver disease and will have normally measurements above the cutoff value of cirrhosis. So the clinical impact of the finding is limited in many cases. And for people with ascites without evidence of advanced fibrosis, I would be very carefully when interpreting liver stiffness, because there's not much evidence what liver stiffness tells us in such patients.
Thank you so much. What is the main advantage between point shear wave elastography and 2D shear wave elastography?
Yeah, point shear wave elastography was the first method which was available for the market, and many studies have been performed using this technique. So it's better evaluated in chronic liver disease than 2D shear wave elastography is. The advantage is that you have a small region of interest which you can place wherever you want, and you can precisely avoid vascular structures or bile ducts. On the other hand, it's a small region of interest, and results may be influenced by the choice of the region. And in 2D shear wave elastography, you have a wider possibility to put your region of interest. You have an optical feedback that you have a good measurement position, but still some of the methods require further evaluation, especially regarding the many modifiable factors such as region of interest, size, position, etc.
Third question, do all the manufacturers have published cut-off values?
not yet for all the diseases. So for the transient elastography FibroScan device, where we have the highest evidence, there are cutoff values published for almost all chronic liver diseases, especially for rare liver diseases like Wilson's disease or cystic fibrosis. You will find cutoff values. For point shear wave elastography, you might have some difficulties in finding cutoff values for rare liver diseases, but you will also have cutoffs for all common chronic liver diseases. And 2D shear wave elastography methods, especially from manufacturers which have provided their devices very recently, you will have problems in finding precise cutoff values for different liver diseases.
There are quite a few more questions, but to be in time, I would love to discuss that additional questions at the end, perhaps to all the presenters. And dear audience, we received your questions and we will nicely answer thereafter. So Thomas, please stay on stage until the end, because there will be very interesting more questions to you. One more time, thank you so much.
Okay.
So all what Professor Karlas has pointed out can be seen on the FSUMP guidelines, and if you put in your computer in the Google search FSUMP, you will find the elastography guidelines from FSUMP free to download. So please visit our website fsump.org, Google FSUMP, and you will find all that information.